Welcome to our second set of notes in this unit on mental illness and treatment, where we are going to talk about a couple categories of disorders, one being anxiety disorders and the other two categories being obsessive-compulsive and related disorders, and then stress-related disorders. So we're actually talking about three different categories. If you check back in my YouTube channel, which I would love it if you would subscribe to that, you will see where in the first set of notes, Intro to Mental Disorders, I describe how all of these used to be under one category of anxiety disorders, but now they are separate. So there's anxiety disorders, then obsessive compulsive and related disorders, and then there's stress and trauma related disorders. So let's jump right in. So let's talk first about some prevalence, because again, we're not just learning about this to do well on the test. We're learning about this because we're talking about human beings and their life experience. According to the Anxiety and Depression Association of America, anxiety disorders are the most common mental illness in the United States, affecting 40 million adults age 18 and older, and that's 18.1% of the population every year. And according to the National Institute of Health, an estimated 31.9% of adolescents between the ages of 13 and 18 had an anxiety disorder. Now, that was using the DSM-4 criteria, so that very well could include anxiety disorders like the ones we're going to talk about, as well as OCD, obsessive compulsive, and even PTSD and trauma or stress related. So those are now three different categories, but still very prevalent. So you just never know who. This man, his name is Tony Dorsett. If you don't know him, he's one of football's greats, and he makes no secret of his fear of sleeping in the dark and that he has a phobia, and he'll admit it to this day as a grown man that he leaves the bathroom light on and the door cracked in his bedroom when he's sleeping, and there's always a ton of lights on in his house. He very much has a phobia of the dark. Another one being John Madden, right? A large football guy, right? Used to be the head coach of Oakland Raiders and is now a TV sports personality. He suffers from panic attacks when he is on a plane. So now he never flies. He only travels in a luxury bus. So someone who's, right, really, really well known, and he suffers from anxiety. So I briefly talked about this, but the new categories of disorders you do need to know, and that they used to all be under anxiety, but now at the bottom here in the DSM-5, you need to understand that anxiety is its own category, including these three separate. So maybe I should have had three separate boxes, but GAD, panic disorder, and phobias are all three different disorders. So then OCD and related and trauma and stress related are separate disorders according to the DSM, and we'll talk about why. Some general qualities of anxiety disorder include worry, and that really I think a lot of people have a very good understanding of what anxiety is, but it's good to just put some words to it. Worry, fear, apprehension, intrusive thoughts, meaning ones that you don't want in your brain. Physical symptoms and feelings of tension, they seem to have an automatic quality to them. So like a knee-jerk, uncontrollable reaction. It's not that someone wants to feel, think, or behave a certain way. It's just that it happens. It just happens, and if they could get rid of it, they would. So we have these three: GAD, PD, or panic disorder, and phobia. So we'll start talking about general anxiety disorder first. This is the prolonged, often vague, and unexplained but intense fears that do not seem to be attached to any particular object. I would write that down and highlight that, because that's really the marked aspect of GAD, and that there's really no telling, again, write this down, where their anxiety is coming from. They just have this underlying, prolonged, don't know why, don't know where it's coming from, anxiety. Studies show that between 4.1 and 6.6% of the population have experienced GAD. It is more common among women and tends to become evident between late teens and early 20s, and that you just feel this overwhelming sense of anxiety all the time, and you don't know where it's coming from or why it's there. You don't have one particular thing that you're afraid of or worried about. Symptoms include excessive anxiety and worry occurring for at least 6 months. So this can't be a seasonal thing in life that has kind of a specific cause. Inability to control the worry, considerable distress, there's that D word again, or impairment in social, occupational, or other important areas of life and relationships that you have. And then the presence of 3 or more of the following, that there's restlessness, easily fatigued, difficulty concentrating, or like the mind goes blank, irritability, muscle tension, and sleep disturbances. All of these things making a lot of sense if someone is experiencing that kind of underlying prolonged anxiety. Panic disorder is separate. You should make a note that oftentimes people with GAD also have panic disorder. But they are still separate. So someone would be diagnosed with GAD and, meaning with panic disorder. Indicators are similar to GAD with panic disorder, except that they are greatly magnified and usually have a sudden onset. It's not just kind of growing over days or months. It's instant and it comes on quick. It's more common among women and younger people. The clinical features being it's recurrent, it happens more than once, it's unexpected, and it's a panic attack. It's an attack on, almost like an attack on the nervous system. It's really amped up, that lasts a month, or persistent concern over having them again is also a marked symptom. So there's shortness of breath, feeling smothered as if, there's something stopping you from breathing, which then causes dizziness, unsteadiness, or faintness, trembling, shaking, sweating, racing heart, right? Any of these things that you might think might happen in a panic attack. Choking, nausea, stomach pain, numbness or tingling, chest pain and discomfort, a sense of strangeness, and that it's an unfamiliar place, an unfamiliar feeling. Fear of going crazy, losing control, or even dying. So that really intense fear. The last one under anxiety disorders is phobias. This is marked by a persistent and irrational fear. So it's important for you to underline and highlight irrational, and that, sure, these things could cause some harm, right? They could cause danger, but your response to them is not logical. It's not necessary, and it's causing some distress, right? So it's an irrational fear, an object or situation that disrupts behavior. And this chart kind of shows you some common ones: specific animals, heights is a big one, blood, and oftentimes accompanied by a needle, right? Sometimes closed spaces, so claustrophobia, water, storms, being alone. People with phobias know exactly what they are afraid of. So this is very different from GAD. But the fears are out of proportion with reality. So they seem inexplicable and are beyond their voluntary control. I don't want to be this afraid of blank, whatever it is, but I am. And it's not I can't control it. So it's important for you to get these kinds of phobias. A specific phobia is what you normally think of when you think of phobias. It's the irrational fear of a particular object. So spiders, claustrophobia being closed spaces, water, that kind of thing. A social phobia is fear of embarrassment in interacting with others. So it's the fear of being social, of being in an environment, being embarrassed, being around other people. You need to make sure that you have an understanding of how that social phobia is different from agoraphobia. Agoraphobia is the fear of fear itself. You should make sure you write that down. Fear of entering certain fear-evoking or unfamiliar situations. So that's why it's fear of fear itself. It's fear of where you might be fearful, which often accompanies panic attacks. So agoraphobia is very much accompanied by panic attacks. So this person avoids crowds where the attacks could occur. And it's not just crowds, it's any situation where the attack and therefore intense fear of this phobia they have may occur. So oftentimes what you find with folks with agoraphobia is that they never leave their home, because even though they may know that let's say that it's a fear of an elevator or enclosed places like in an elevator, and they're afraid that they're going to have this strike of fear and a panic attack in an elevator. They may know that they are going somewhere where they will not get on an elevator, and that there are stairs available, but they still won't leave their home just for the chance that they might not be able to avoid the elevator, and that they would rather stay home in their house, in many cases for months and years, never leaving their home, just to make sure that they avoid that fear-evoking situation. So let's shift from anxiety disorders into obsessive compulsive and related disorders. This is OCD. Okay. And one kind of myth busting that I need to do, I guess that's a word you could say, is that when someone says, oh, they're so OCD, they want everything in a certain order and all of that. Here's the thing. There is a difference between anal retentive personality and tendencies. There's a difference between obsessive compulsive tendencies and personalities. That is similar, but very different from obsessive compulsive disorder. Just because someone likes everything orderly or might wash their hands often doesn't mean that it's obsessive compulsive disorder. So it's important for you to really pay attention here and see, okay, so what's the difference? It's the persistence of unwanted thoughts. I want you to also write down intrusive thoughts. So these are thoughts that the person does not want in their brain, but they get in there anyway. So that's the obsession part. So you might want to write down obsession equals intrusive thought. That keeps recurring. It's persistent. Accompanied by the urge to engage in what is senseless rituals that kind of alleviate the obsession. And these are the compulsions. So I would write compulsions equals senseless rituals to alleviate the obsession. And this is where the disorder comes in. There is a neurological connection, and I'm kind of simplifying this, but there is a neurological connection in the mind of an OCD patient between the compulsion, which is frankly ridiculous, right? There's no explanation for it, but there's a connection between that compulsion, that ritual, and this obsession. So let's say that the intrusive thought that this mother's son is going to die. Okay? He's healthy. He's safe. Sure, anyone could die at any moment, but hers is an obsession and it keeps entering her brain around the clock. And she has these compulsions where she has to turn the lights off and on, or turn the faucet off and on, or turn anything that turns off and on a certain number of times in a certain consistency, or he's going to die. That's the irrationality of it. There is no connection between those two things, but in her brain, it's connected. And that's what makes it a disorder, not just someone who likes things that are neat. So you've got to get down the cycle, and that the person has this intrusive thought. They have intense anxiety and stress over it. So they do this compulsive ritual because maybe it'll help. It gives them a sense of relief for a short period of time. The obsession comes back. And it's just this very ugly, hard to get out of cycle. People with OCD do not seem to, quote, know anything with certainty. So they don't trust their own senses. So they do these things. They do these compulsions and rituals over and over again because they don't trust that it's going to be okay. They don't trust that sense. They don't trust their own decision making. Therefore, if they don't trust their own decision making, what part of the brain would a biological psychologist say is affected in the brain of an OCD patient? Decision making, right? It's going to be in that prefrontal cortex or the frontal lobe. So some brain imaging of PET scans of a brain of a person with OCD, and that there's a high metabolic activity, meaning the red that you see here on the screen in the frontal lobe areas involved with directing attention and decision making. So now we need to make sure that we discuss some OCD-related disorders. And I want you to keep in mind that they are under obsessive compulsive disorder and related, because they are related, right? So for instance, let me kind of explain this. Body dysmorphic disorder used to be considered what was called a somatoform disorder because it was of the body. Trichotillomania, as well as exoriation disorder, is also of the body, but that doesn't make it a somatoform disorder because it involves such noticeable, I guess you could say, compulsions that surround some sort of intrusive thought. So let's talk about briefly body dysmorphic disorder, because we're going to talk more about that in a second. It's the preoccupation with an imagined or exaggerated defect in personal appearance. So again, exaggerated, that someone might have a large-ish or larger nose, but it's exaggerated in their minds and they can't stop kind of obsessing over that intrusive thought. The essential feature of BDD is the belief in an imagined defect in appearance. Hoarding disorder, you've probably heard of this before and just thought, oh, they have a problem getting rid of things, but it's so bad that it's disordered, right? It's dysfunctional and somehow deviant and messing with their lives. Persistent difficulty to part with possessions because of the perceived need to save them, no matter of the lack of value, and there's distress at the thought of getting rid of those items, severe distress. Trichotillomania is the hair pulling disorder, the recurrent irresistible urges to pull out the hair from any part of the body, not just the scalp, despite trying to stop. So again, there's some intrusive thoughts there, and the compulsion being the pulling of the hair. Exoriation disorder is skin picking, where the patient repeatedly picks at their own skin, resulting in lesions and causes significant disruption in one's life. And that it's not just like some kind of tick or habit, right? It's very much disrupting their lives. Let's talk more specifically about BDD. There's this preoccupation, right, of this perceived, imagined, or exaggerated defect, let's say in appearance, and it's time consuming, often being about shape or size of facial features, acne or spots on the skin, wrinkles, thinning hair, scars. And individuals with this experience marked distress over their supposed deformity, right? Lots of distress, feeling self-consciousness about their quote defect may even lead to avoidance of work or public situations. And they do have higher rates of major depression and suicidal tendencies. And BDD typically becomes evident in adolescence, right? When there's more focus on what you look like, and it does affect males and females equally. These are some examples of what individuals with BDD, quote, see when they look in the mirror, in that it's not that they see this exact image, right? She doesn't believe that her skin is actually that long. But when she looks in the mirror, it's exaggerated to her. It's all she can look at. It's all she can see. I say she because of the images here. Again, it affects both males and females equally. And again, it's an exaggerated feature. It's not that they actually look that way. It's that they might have large ears, or you know what, she might have a long chin, but that's all they see when they look in the mirror, and it's exaggerated in their eyesight. Human, quote, Barbie has resulted in more than one case. This is Sarah Bird. She's 50 years old, probably older than that now. This is a little older. From the UK. She's had over 100 procedures costing over $1 million for various cosmetic enhancements. Recently in the news for allowing her 16-year-old daughter to begin Botox treatments. And then again, this is her at 50 years old after 100 plus procedures. And this is her when she was a little younger, before procedures. And again, it's just seeing things that are wrong with you, quote, wrong with you, and they're very exaggerated. And obviously this is causing her some kind of distress if she's willing to spend millions of dollars on it, and it's very time consuming because it's the intrusive thought. She's obsessing over it. The last category we'll talk about is trauma and stressor-related disorders. The biggest one here being PTSD, or post-traumatic stress disorder. Something and kind of a myth busting we need to do is that oftentimes the prototype, there's a vocab word for you, that you might think of is a soldier. And of course, yes, they go through trauma when they're in combat soldiers. And yes, they experience PTSD at higher rates, but that's not all who can experience PTSD. Anyone who goes through trauma or heightened stress in their life. So victims oftentimes, right, of whether it's robbery or abuse, assault, anything like that, can experience PTSD. It's got to be 4 or more weeks of the following symptoms, and that's what constitutes PTSD. These haunting memories, nightmares, and flashbacks, and therefore social withdrawal because of a lot of these symptoms, and just because they can't get away from these haunting memories, jumpy anxiety and thinking about it with those haunting memories and flashbacks, and that also causing some sleep problems. Now, there is some resilience to PTSD to kind of keep in mind, in that only about 10% of women and 20% of men react to traumatic situations and develop PTSD. So of all people who have traumatic instances, it's not a ton, right? Like, a lot of people are impacted by trauma, so you would think that this would be more prevalent. Holocaust survivors have shown remarkable resilience against traumatic situations. And then all major religions of the world suggest surviving a trauma leads to growth of the individual. And that it's not that you want to live your life avoiding trauma, although that's probably a good life choice. But don't think that just because you experience trauma that you will then have PTSD. Also, don't believe that just because you may be a victim or have experienced trauma that you are automatically disordered, or that the way that you are handling it, even though that might be a traumatic instance in itself, don't think that that's disordered necessarily. Other than PTSD, there's also acute stress disorder. This is very similar to PTSD. However, it starts immediately after the trauma, whereas PTSD normally has kind of like a period in between the trauma event and the disorder occurring, the behavior. And then the acute stress disorder lasts from 3 days to 1 month. So it's a little more intense, but it's shorter lived. These two, acute stress disorder and PTSD, were previously considered anxiety disorders. Duh, I've said that a lot. But they're not anymore due to, and I wanted to tell you why, because not always do these patients experience anxiety, right? And that they have this stress, they're responding to trauma in a certain way, but that doesn't mean they have anxiety about it. Rather, they may experience, although they could still experience anxiety, or just anger, aggression, or dissociation and other symptoms, not necessarily anxiety. So it couldn't always be considered an anxiety disorder. So let's talk about the perspectives and what they have to say. The learning perspective saying or suggesting that fear conditioning leads to anxiety. So think of this particularly with phobias. This anxiety then gets associated with other objects or events like stimulus generalization and is reinforced. So fear responses are inculcated through observational learning. Young monkeys develop fear when they watch other monkeys fear snakes. Observational learning. And the biological perspective, with GAD, panic attacks, and even obsessive-compulsive disorder, it's linked with brain circuits like the anterior cingulate cortex, and that they have found a specific spot, again in the OCD patient, more active in the prefrontal cortex, but that the OCD patient and other patients of anxiety have this specific brain region that's impacted. So thanks for tuning in. Be sure to stay tuned for our next set of notes, which will be, I think it's either dissociation, possibly formerly mood disorders, but stay tuned and you'll see which one. Have a great one. Thanks.